Where'd he go?
Yeah,
Did it right way. Thanks.
Okay.
yes.
Ladies and gentlemen, we're going to start in about 5 minutes. If you have a question for the panel, we do a moderated town hall here, which is you fill out a comment card, and Dave Martinez or John Scott, one of our staff members, John's right here in front, he'll help you with that. And if it's a question of general interest that we can ask here, if that doesn't violate somebody's personal information or their privacy or their healthcare information, we'll try and ask that question here. If not, if it's something that we need to take offline, we will try to probably get you out here with a specialist today to work that issue one-on-one, and we'll get somebody to contact you here within the next week. But so it's real important that you put your contact information on here too if you need a response. But John up here has the comment cards, so right as we get started, I'll just ask you if he's helping the customer up here, we'll just ask you to raise your hand if you want to comment. So give us about a couple minutes to make one more announcement and try and let a few more people know we're starting.
Attention in the facility, attention in the facility. The quarterly town hall meeting will be held in the auditorium at this time. Please come to the auditorium and fill out a comment card with questions for our VA leadership. Also, for your dining pleasure, the canteen will be open until 2 p.m., 1400 hours today. Thank you.
All right, good morning, ladies and gentlemen. I'm Chuck Brady, I'm the Chief of Public Affairs for the VA Southern Nevada Healthcare System, and we'd like to thank you for taking time out of your day to join us for our quarterly town hall and Veterans Resource Fair today. So our town hall will last about an hour, and just to kind of give you a heads up, if you have not been to one of our town halls before, we've changed the format based on feedback from veterans in the community to make these events more productive and more informative and educational for our veterans. So we do what is called a moderated town hall here, and what that is if you've got a comment, question, or concern, we have comment cards. John, please raise your hand. Can get those to you. We ask that you put down your information on the card, and we'll take that. And if the question is something that we can address up here of general interest that doesn't get into a person's personal situation or violating their privacy, we will try and address that for the general audience here. If you have an individual issue or need, we will try and get you with a specialist out there, either from the benefits side or the healthcare side, to assist you with your concern. We have several different specialists out here in a variety of areas, including enrollment, benefits, billing, etc. We also have our patient advocates out there. So we have a bunch of people here who can help you out today. Obviously, our thing, and the reason we do this format is we want to turn this more into a constructive, informational, educational format, as well as help you address your needs. So if you have a comment, question, or concern, please raise your hand. Mr. Scott will bring you a card for us. So what we'll do is we'll start out with some updates from our leadership here. We have Ms. Peggy Kearns, who's the director of the VA Southern Nevada Healthcare System. Dr. Mahmoud Kamanduri, who is the chief of staff for the VA Southern Nevada Healthcare System, and Ms. Kelly Stillman, who is our OIC for our Las Vegas office for Veterans Benefits Administration. So they will start out with some brief remarks and give you some updates on what's going on here at the facility, and then we will move toward the moderated Q&A session. We'd like to thank all our community partners that are out here today. We have about 50 represented out in Holly, so I would encourage you to go out and see some of those organizations and pick up some information from them as well. So about 20 different representatives or agencies represented from our VA Veterans Benefits Administration out there. So please take that time to get some information from them. We'd also like to thank and welcome our congressional representatives who are here today. We have Ryan Detail. Ryan is with Senator Dean Heller's office, works with us on veterans issues. And then we have Ms. Alana Simpson, who is with Senator Catherine Cortez Masto's office as well. So both of them work with us regularly to help our veterans with their needs and their issues, and we are happy to have you both here today. So thank you for joining us. So I will turn it over to Ms. Kearns to start out with a veterans health update.
Good morning. So I just wanted to go over a few things of how many people we saw last year. People always want to know some statistics of how many veterans we serve and on that. So we have in our system 79,773 enrolled veterans. So they are enrolled for health. Of those 79,000, 61,694 did care here. So last year we served over 61,000 veterans in our 4 clinics, our 6 clinics, and this facility. This past year, we served 7,998 OEF, OIF, OND veterans, so our newest veterans. We served over 5,600 female veterans this past year. Inpatient admissions, we had 5,663 inpatient admissions to our beds here at the hospital. We had 26,000 inpatient days of care, and an average daily census of 74. So we have 90 beds here. 70 of them are medical surgical, and 20 of them are psychiatry. Okay. We also did, and this one might blow you away, as always does me, we did 1.3 million phone calls into this facility over the last year. So if you have trouble getting through the phones, it's a challenge, because answering that many phone calls is a challenge. So we want to really encourage all of you that have an opportunity to do My Healthy Vet. I know we have some people out there. That's our system where you can email your doctor or your nurse and get your answers that way rather than have to wait on the phone. So if you haven't done that, see our folks out there. So the Secretary of VA has given us 5 goals this year. The first one is greater choice. So we're going to implement some new programs for you this year. One of those is auricular acupuncture for smoking cessation. That's where they stick the little needles in your ear and help you quit smoking. You got that already? Great. We're going to implement pain medicine community education, and Dr. Comandori is going to talk about the opioid crisis that is going on and all the changes that are happening in the state, and that the VA has already been doing for about the last 5 years. So we're going to hit on that. Under modernized systems, we're going to implement a telehealth sleep clinic. So we're going to have somebody in Chicago working with our veterans on sleep issues via telehealth. So that'll be an interesting new one. We're going to be starting a telestroke clinic. So what that is a doctor at another VA will be able to call them if we have somebody in our PD that may be having a stroke, and consult on how to take care of them, whether they can stay at our facility and get cared for, or whether they need to go out to one of the stroke centers here in town. So that's a new one. We're going to obtain approval to begin Da Vinci robotic surgery. We have our robot, it's here, and now we have to get our physicians trained, our surgeons trained, and we hope before the end of the fiscal year, which is September, that we'll have done our first robotic surgery. So that's exciting. We also are going to be implementing what's called tele-ICU. And Dr. Comandori can talk a little bit more about that, but it's where we can dial up another facility, it's in Minnesota, and they can consult us on folks that are in our ICU. So it helps us with, we have a lot of trouble in this community finding specialty doctors. And this is one way that we can do it and have the doctor be somewhere else and our veteran here. We're looking at all kinds of things to improve timeliness of access, timeliness of care. And the Secretary's biggest goal this year is suicide prevention. And so we're working with our Veterans Community Engagement Board, and they are the folks who put on this fair today. Okay? They are a group of about 40 to 50 different community organizations that we work with, and they planned this whole transition fair for today. And I really want to thank them for being part of this and for putting all the work into getting all the different organizations here today. You're going to see something start this next week. It's called the Red Coat Ambassador Program. So we have veterans that have volunteered to become ambassadors. They will wear a red vest because we're not doing coats. It's too hot here in Vegas to wear a coat. So we got these nice red vests, and they will be available throughout the facility to help veterans get around the facility, answer questions, and that. So that's another new program that we're starting. And of course, we continue to work on zero homelessness for our veterans. The point in time count of homeless veterans is at the end of this month. And so we'll be going out and we have social workers that are going out every day trying to find veterans and get them into housing. We actually are at functional zero here in Las Vegas. We actually have the 4th largest homeless veteran population in the United States. We were 3rd, so we have to prove it. But there are still veterans out there that need a place to live. We have vouchers for them, we just gotta find them, and then they have to want to get housed. But that's still a big push that we're doing for our veterans. And then on your chair, you have the VA to the point. This is our quarterly newsletter that we do with different information, mostly health-related information. But on the front today is an article about feedback surveys. So if you're an inpatient or an outpatient for us, you might be selected randomly for filling out a survey. And what we ask you to do is please fill out the survey. It's really long, so that kind of turns off some people. We've talked to central office about this, and it's a little bit long, and I don't, people, if they made it shorter, maybe more people would fill out. We're looking for your feedback so we can improve. We know we're not perfect. We know we don't do everything just right, but we're always looking for those things that we can improve. So I want to thank you all for being here, and I'm going to turn over to Dr. Comandero to just talk briefly about the opioid crisis and some of the things you may have been reading in the newspaper recently.
All right, good morning, everyone. Thank you so much for coming, and thank you for using the VA. We wouldn't be here, so it's very important that we always keep that in mind. So thank you for your service, and thank you for using the VA to take care of you. So first, let me talk about 3 different things. First, let me talk to you about our recruitment, where we are, where we stand. As you know, this Nevada ranks 49th or 50th when it comes to healthcare services for whether it be doctors and nurses, a lot of healthcare professionals, difficult to recruit and retain. And some of it is, we don't have the medical schools, which they're just opening at UNLV, so that's just started. But many places, they've been established for decades, so it's a little different here. We're just trying to build it, Where I went to medical school, UCLA is now, starting next year, will celebrate their 100th anniversary. So they're 100 years old and we're 1 year old. So so we want to get there not in 100 years, but hopefully we'll get there much quicker than that in Nevada. So we can take a look at how do we get to rapidly get to that. So we're working with the university to recruit and build programs and residency fellowships. In fact, Ms. Kearns and I signed off on all of the fellowship programs that we work with the university, which is in cardiology, we work in GI, pulmonary, and critical care. And hopefully as the university grows, as the medical school grows, they'll bring other specialties that they don't have in Nevada. If you need a transplant surgery now, you have to leave the state. There's nowhere in Nevada can you get it. Hopefully we can build those kinds of subspecialty here. So we're working with the university to build that both in UNLV and Toro and University of Nevada, Reno also. So we work with all of them, and Roseman University to build a specialty program. So we work with that. What are we doing with our own recruitment? The positive things is we've been able to recruit and hire really a super subspecialized trained thoracic surgeon, and she's on board starting. And in fact, just yesterday we read next month she'll be doing her first biopsy using endoscopic ultrasonic biopsy. There are only 2 hospitals in the entire southern Nevada that actually use this endoscopic ultrasound biopsy procedures. That is the VA here and Nellis. And no other facilities could actually even have that expertise to do it. So we've got some really solid people. We continue to recruit. It's not easy to find. As you know, we've been short-staffed. In certain areas, it's been difficult to find. Cannot find urologists anywhere in the country, it seems like. So it's a real challenge to find urology or ear, nose, and throat surgery. Subspecialty surgical areas have been very, very difficult for us to recruit, but we continue to do that. And some of the medicine subspecialties are also difficult to recruit, but we're still trying to do the best we can. Where we can provide the care in-house, as you know, we utilize a couple of other mechanisms. One mechanism is obviously the choice program, and certainly you'll hear about that. But the other mechanism is telehealth, as Ms. Kearns talked about. So telemedicine is critical. We're working with other facilities to coordinate Our doctor, one of our neurologists here, is already part of a telestroke program. Currently, as we speak here, he takes call for other rural VA facilities and provides telestroke consultation from Las Vegas. We will now, as he's doing this, we will become a part of this, and we will be able to provide telestroke services here. So if somebody comes in with symptoms of a stroke, we literally wheel in essentially it's an iPad type of a device into the room, and he can actually see, the neurologist can see, no matter where they're at, that patient, and then give us an advice to the ER, what should we do the next steps to manage that stroke. So we're going to be a part of the telestroke. Tele-ICU, intensive care unit. We're first working with Minneapolis so they can help us provide ICU coverage, because we really only have one intensivist on our staff, and that's our chief of medicine. So we're trying to figure out if we can get additional support. The Tele-ICU is an amazing program. They've already implemented across the Midwest. We will be kind of the first West Coast location. And the goal is you can literally provide intensive care unit coverage from a remote location and provide, but essentially video advice to the staff that's taking care of the veteran at bedside. And this is not just the VA, but the private sector, universities, they're doing the same thing. So you'll hear telemedicine is another mechanism of rural care. The second thing I want to talk to us about is suicide prevention. As you know, that you've seen the data information about 20 veterans a day committing suicide, and how do we change that? How do we prevent any suicide by a veteran? What can we do to improve that? Now, the suicide is really tragically an epidemic in our society, both as a veteran and the civilian population. And now, what can we do to change the trajectory in the process? And the way we've taken is, one, the VA is going to go out and work with everyone, because many of those veterans who may commit suicide don't ever contact the VA. Only 6 of those will actually contact the VA. 14 or not have no contact with the VA. How do we connect with those veterans? There's been a few things that have been done. One, just recently, the Secretary of VA opened up mental health services for veterans who have, let's say, dishonorable discharge or other than honorable discharge, so they can still come in and get mental health care services. So that in those cases, maybe they didn't have access to mental health care, we can at least provide some mental health services as we coordinate them, and maybe they can change their discharge. So that's one option, is to get a hold of some of the 14 that don't come to us. The other thing is going into community settings. We have 5 suicide prevention coordinators. We have, I speak loud enough, sorry. Can you hear me, or you want me to hear you? All right, we have 5 suicide prevention coordinators that are actually going out, working with community organizations, with universities, all kinds of other settings, to actually link with the veterans that are not coming to us, the 14 that go to the VA. How do we connect with them? How do we reach them and offer additional care and services for them? So we'll do our best to figure out a way to do a better job. And really, suicide prevention is all our responsibility. So how do we work with veterans organizations, community organizations, whatever it takes, the ones that don't come to us, to address the depression, and also address access to weapons and gun safety and mechanisms. So they've actually done some unique things. They've actually gone up to the gun range and offered folks, if they want options to have gun loans, just so have one more step before somebody can access their weapon, which is the most common mechanism for people to commit suicide nowadays. So little steps that we can take to change that and provide really solid mental health care. We're expanding our mental health services. We're fortunate to be hiring more mental health providers here, and that's good news to be able to access and provide care. The third thing I want to talk to you about is opioid issues. As you know, opiate is a huge epidemic across the nation. I mean, right now, more people die from opiate overdose than car accidents in the United States. We have a huge, huge problem with the opiate epidemic in every state across the country. And Nevada is one of the worst, tragically, in the state. So a few things have occurred, and what the VA is doing. We've been on this journey to really change the trajectory of opiate use. And in the VA system in Las Vegas, we've been really very involved in how do we change that. And the goal isn't to say we can abruptly cut people off. We've had that happen where some of the doctors in the private sector I've seen, they'll say, I'm not gonna write for it anymore. Well, you don't stop. You know, some of it is the healthcare system created this problem. Several years ago, they said, pain is the fifth vital sign. Everybody was having pain. You must cure and prevent pain altogether. So everybody was writing these medications. So the healthcare system, in many ways, contributed to the opiate epidemic. And now we've had all these problems. How do we change that? So you don't abruptly stop these drugs. How do we work with them? So our goal is to offer a comprehensive pain management program here, which we do. Dr. Asani runs the program. It's very well done. As you know, auricular acupuncture, that's one way to address alternative approaches. We have Tai Chi, and there's yoga, relaxation therapy, right? There's Tai Chi is another program, there's other kinds of approach, mindfulness. What can we do? We have yoga classes going on. We have a psychologist who does yoga instruction. Not saying that's a cure-all, but all of these are good steps, alternative approaches to change the opiate use and not have a problem with opiates. So with regard to the opiate prescription, 2012 we had about 24% of our veterans use opiates, our population, and we've been with the diligent effort and slowly working ways, not abruptly cutting off. We've reduced that rate to about 16% of our veterans, and we want to reduce it further. So, because we know that these things shouldn't be the first line, really looking at alternative approach should be the first line. So there's two approaches to it. The initial first VA opiate safety initiative was to reduce the super high dose of opiate prescription. And that's been a huge problem where the massive dose of, so that's one approach. And we have had a dramatic fall. If you look at our graphs and data, dramatic decrease in the super high dose of that. The next step is a really bigger, more complex step. How do we change the reception and the start of medications? That we don't reach for the pill less. Yesterday I was talking to one of my colleagues and he said, you know, eventually our patients will not come to us for medications. Eventually you'll just essentially have a little ATM machine. You go up, these are your symptoms, this is the pill you get. They'll come to us because of the relationship and connection to us. So it isn't just the pill that's the approach that we need to take. It is what can we do to the complex approach of pain? How do we manage it? So one, not to start these drugs and start them in various, there'll always be patients who will need this. There'll always be patients, of course we do, right? We realize that. So one, we have to address how do we start them in the appropriate cases to start. That's one. Second is to avoid the super high doses. So we're addressing both ends of the spectrum to change the trajectory of the opiate use. So it is a challenge. It's not going to be easy. Nevada is a very difficult state. We've had a huge period of opiate prescriptions. Now, Nevada state legislature recently created a law that's one of the most stringent in the nation that's creating a lot of challenges because now doctors in the community are saying, well, we don't want to write for it. Well, you can't stop writing for it. But so there's like 16 steps you have to take in order to write opiates now. So what we're going to get, and I can guarantee you, many veterans will essentially leave the outside system and come to the VA because their outside doctors are going to say, we're not longer going to write you these medicines, even though they've actually started them on the medication. They're afraid of the state. So there is work with the state legislature to see how that can be changed a bit so that these doctors are afraid that they'll lose their license anymore if they write for these medicines. So we have to find this, not this extreme pendulum swing. We need to find some balance of, there'll be people who will need these medications, and some in high doses, etc. They will need them. But vast majority of them, we have to have alternative ways to manage it. All right. And I'll stop it here for now. Thank you.
Thanks, Dr. Common. Kelly, did you want to read the points?
Morning, everybody. Thanks for coming today. VBA has had a great year in 2017. We processed over 12,000 reading claims, which is double what we did in 2014. In addition to that, we had over 2,000 appeals cases and 2,000 more non-reading cases. We're on track to have that same kind of year this year, so I'm really proud of my team for stepping up to serve the veterans of this state. BBA as a whole is making a lot of changes to modernize systems and processes. There's the Appeals Modernization Act. There is the changes to the GI Bill, now called Forever GI Bill. We have modernized our claims processing systems, and we're just working towards the Secretary's goal of improving timeliness by changing our laws and regulations so that we can get you guys decisions faster. So I'm really proud to be a part of this community. Your community education board has so many great members that take care of veterans. It's just a great, great community that takes care of veterans, and I thank you all for coming.
All right, thanks, Bill. All right, so that is our opening and our intros and updates there. We'll move on from there. Just once again for the ground rules, anybody just walk in here. This is a moderated town hall session, so if you have a question, John Scott is in the back there, and David Martinez, they can just raise your hand. They will bring a comment card, and then you can fill that out, and we will bring it up here to the moderator, which is myself. And if it's something of general interest, we will bring it up here as part of the session. If it's something of a personal nature, we will work with you to get somebody to help you here today or after this town hall session. So Dr. Comanduri, let's kind of start with you. So you talked a little bit about the opioid crisis. Now, I think the one thing you mentioned, you did say that the percentage of veterans who receive medications here that are opioid related has dropped from 24 to 16%. But I think another important stat that you were talking about that high dosage of that is, I think statistics that came out this week also said that we reduced the amount of opioids that this facility distributes has increased by 33% in the same time frame when we've seen some rapid growth. Did you want to talk a little bit about that part?
Yeah, and again, this brings up the point that this VA, we're very fortunate, many VAs are really not growing. In fact, a lot of VAs, as many places across the country, are actually shrinking. It's just fewer and fewer veterans living in locations where, like colder climates, veterans are moving to warmer climates, right? So we're seeing that. We are fortunate. We are one of the top 10 fastest growing VAs in the nation, which is a great place to be. This is the place, the VA will and needs to put more resources. As we continue to add more resources, this is a place to be because this is where the veterans want to come. They want to get care here. Now, even with that growth, as Chuck said, we really still reduced our number of percentage of veterans who use the drugs, and it's reduced by 33% the amount of opiates we distribute or send out to veterans. So, and the goal is not again to abruptly discontinue, but slow and steady. The other important thing we're doing to prevent overdose, the risk of overdose, is you're giving naloxone kits that are being distributed to many veterans who take opiate medication, just to prevent an accidental overdose. You'll see naloxone available widely. It will be available for first responders. It's already there for them. You'll see police officers. You're going to probably see it in public settings like in casinos, just like the AED that they have if somebody has an automatic external defibrillator if they have a heart attack. You're going to see naloxone in this. And in fact, some of the casinos actually start training their staff. It's just a nasal spray that will quickly reverse the opiate overdose, and then we can get further emergency care. So you'll hear more about that.
All right, thanks, Dr. King. I'm going to kind of tag on to that too, because the other question we get from a lot of veterans and being a government agency, I know there's some rules and regulations. A lot of veterans feel like we can curb the opioid crisis by being able to get the medical marijuana or cannabis, but obviously there's rules and regulations. A lot of people, I think the reason I bring this up is a lot of people feel like that veterans can't talk to their doctors about their medical marijuana use as part of their care. And I know that everybody feels like the VA just changed its rules on that, but we've been doing that for quite some time in the states, especially here in Nevada. So I think we probably should educate people on that, just real quick.
So the VA, we as physicians, we can certainly discuss marijuana. We cannot prescribe or recommend by federal authority to use, tell somebody, go ahead and go use marijuana or obtain marijuana. So that, as you know, we have both recreational marijuana and also prescription marijuana. But what we can say, have that as a part of a comprehensive discussion with regard to the treatment and care of patients. So there may be the challenges that we have not enough of significant evidence for all the value or benefits may be there. I'm sure there's certainly going to be a role for something like for cannabis or cannabis or oils. There may be some role for this in the future. We realize there's a role, but there isn't right now widely accepted. And the other challenge is, as you know, it's federally still illegal and class 1 drugs. So there's, according to the federal government today, it is classified in the same group as LSD, is considered one that does not have a medical use as of now. So that doesn't mean that Congress is not going to change the rules. That may happen in the future. So we can discuss this as a comprehensive board. The challenge is we face situations come to us and say, I want to take my opiate medications, I want to take marijuana. Well, that creates a big challenge. Now you have somebody out on the street driving down the road with both pain pills, marijuana. What's the impact of all of that? So that creates a lot of challenges, but we can certainly discuss it.
Thanks, Dr. Norman. All right, Kelly, I wanted to ask you about this. We've had this question come up in the last 3 town halls, and just like get another update on it. Decision rating claims, that is a big thing on the BBA side about making sure that we're able to quickly turn decision rating claims and working with our BSOs to do that. Can you kind of provide an update on where we're at in Nevada and what vendors can do if they want to try and get a decision rating claim through the system?
Yes, so unfortunately, we still have not received a claim through the decision making process in the state of Nevada yet. The program was introduced in July of 2017. It's a new process where we're able to provide a decision within 30 days of receiving income. When it was originally introduced, it was limited to claims for increase only, but legislation changed in December, allowing us to process almost every claim as long as you have previously filed a claim and received a rating decision from BBA. So it's open to DXC and claims for service connection, presumptive conditions, secondary conditions. There are a few stipulations. One is that the disability can't be on appeal, can't have a current pending claim, and you work through your BSOs to file the claim. So the reason we're able to process these so fast is because the service organizations help the veterans gather all the necessary evidence, so sometimes we can even make a decision the same day we receive the claim. So tell your service organizations that you want to file a decision on any claim, and we'd love to provide you with that kind of customer service.
Great, thanks, Kelly. All right, one question you may have talked about this briefly, Dr. Commentary, but we've talked to a few veterans out here today. We have a card here about recruiting. There's a perception out there that as staff are leaving our VA, we're not backfilling those positions. And there's kind of, the question is the VA filling those spots that are becoming vacant? What are we doing to better staff those positions? I know you talked about it briefly.
I mean, you know, we have been continuously making efforts to fill our positions of healthcare professionals. This is a difficult community to recruit healthcare professionals. Part of it, like we talked about, they don't have training programs in Nevada, and that creates many doctors. Where they train is usually where they stay, and that's the thing. We need to get more training programs, more specialty. I know wonderful doctors that we've trained in Nevada that would love to become a liver transplant surgeon. Guess what? There is no way you become a liver transplant surgeon in Nevada. You have to leave the state. There's no way you can get it. We've got to, as a really rapidly growing big state, we've got to be able to build these kinds of programs. So we are doing every effort to recruit them. We've asked our congressional representative to help us support, get additional loan repayment programs. Many of our young doctors are now getting out of debt like $300,000 or more. If we can help loan repayment program and have them make a commitment to us, that would help them keep us longer term. So we're making every effort we can.
Great, thanks, Doc. One question that kind of came up too is it sounds like from a person here is it seems like there's a lack of communication. Kind of the question says the care, there's no communication from one doctor to another. What are we doing to ensure our doctors are communicating with each other when it comes to our veterans care?
And communication is such a big issue, not just in the VA, but in the private sector too. We have patients that go out in the community and you literally can't get a hold of the records. If they come back, we don't know what happened out there. Now, one advantage in the federal system, at least, is we have a single record in the VA system. And we have on the CPRS record, have access to the information from one specialty to another specialty. And so we end up being able to read what was written by one specialist to another specialist. And that's one way that we maintain the communication. We have other ways. We meet as doctors in multiple different settings and be able to discuss cases. And right now we do what they call e-consults, so we can do a consult electronically and at least provide a consultation to, as a specialist, to a primary care and other doctors. So there are ways to do it, but it continues to be a challenge. Now, the other thing that's changed in modern medicine, really, in my experience, more than 30 years ago, I wrote all my notes on paper, and it was short and simple. But now you notice the notes are very long, but it seems like there's less information. It's like a lot of the stuff has to be done. So medicine as a whole has to kind of change what we demand and require documentation. There's a tendency to document all this information, but you have to document. But how do we make it that it's valuable, useful information? That's what we need to.
Okay, thanks, Doc. Kelly, this one's for you. What is the current criteria for awarding a non-employability claim? What is the current criteria for awarding a non-employability claim? I guess determining if somebody is unemployable.
So you have to be rated at 70% with one disability at 40% or 60%. And then your disability assessment have to prevent you from having people.
Great, thanks. There's one question here that came up that I think is probably, we do have some representatives from billing outside that can help you. The individual said that they were having problems with paperwork and having to pay money that has already been collected twice. If that individual would go outside, and we do have some VA representatives that can help that individual one-on-one. We have this happen from time to time, and they're very good about working with our consolidated payment center and reviewing the case to see if there isn't being an overpayment and making sure that we get that individual taken care of. So please, if you are that person, we can help you with our billing specialists outside. One comment here was to have town halls on a weekday, not a Saturday. Well, I will tell you this, and when we have them on weekdays, people complain about having them during the day, have them at night, have them on a Saturday. So we're not always going to make everyone happy with the date and time we do these town halls. We do try to rotate them, and we do try to partner with our Veterans Communication Board to make them more useful and educational, such as today with our resource fairs. So we rotate that, but we do try to rotate them around and to a date and time. So hopefully we will have one on a weekday in the future. This one's kind of a security-related question. It says, when will the 11 missing security bollards be replaced in front of the east entrance of the hospital? I'm not aware of any bollards missing there. John? Mr. John Stessel, I forgot to introduce you. I apologize. Mr. Stessel is our acting associate director.
Good morning, but that's currently in a project state, so it should be replaced here this fiscal year as part of the engineering project. So they're in process, and the new ones will be lighted every, I think it's every third month to provide a little more light to here in the dark out.
Thank you, sir. Okay, this one is a mental health related question, Dr. Convery. The question is why was the continuing care of the mental health ADT program changed from a scheduled appointment program to a walk-in program? That's kind of the question.
I don't know if this is a specific group appointment, or is it like a standing group? Traditionally, at one time, everything was just like a scheduled groups repeatedly. So, and it's changed to now, essentially, we to add you onto the group as you come to that appointment, if you come in, if it's a drop-in group. So the programs that are set, let's say they're set for X number of weeks and groups, they will continue to be on a set schedule. But some groups will not be on a set schedule. Some groups will be essentially, if they're drop-in, you would not have a scheduled appointment. That's certainly what you said. Yeah, is that like a travel pay issue? Is that what we're on?
It's a travel pay, but it disincentivizes folks that may be suffering from an opiate addiction thing from continuing long-term care. Because addiction is a lifetime disease. You don't have a cure for addiction. Only the Malibu Passages place in California promises you a cure. So if you disincentivize folks from coming to long-term support care, because you're going to get your $18 no matter what. You know, the deductible from the travel. And the veteran then ends up with $2 or $3. And if you only pay one way, you really disincentivize folks in a high-risk program from getting necessary harm reduction care. I can't imagine that it's very much money. But when you send the message that your care isn't worth round-trip travel, that's the wrong message to send to folks in a very high-risk group.
And again, that's,
For the last 5 years, last 8 years, we paid. So something's happened on the 1st of February to change this hospital or the mental health department's approach to travel pay. And I'm curious as to what the justification is, the regulation, the philosophy to disincentivize mental health care.
I really just don't know, because I don't know the travel pay side of the house. That's the part I don't know, I don't address it. So I don't, John might have better information than that.
If there was any change, and I'm like Dr. David can research this, but if there was any change, it was a national change. We cannot change locally those processes. Those are national guidelines that we do. And so,
And so the travel pay, we don't locally make those decisions and how it's set. And so this was a national change, we have to follow this.
We did it 3 years ago locally, and it had to go through some administrative hoops to stop the mental health department from reducing the travel pay to one way for standing groups. I mean, it went up to the top of the HAS, and Scott, maybe, I forget.
Let us talk about that after.
Yeah, but you talked about opioid addiction as a department critical focus area, but you're not putting your money where your mouth is.
And again, like travel pay is not a local decision, and so I can't answer that question, unfortunately. So I mean, our goal is to take care of those that come to us and figure out to address that. So I mean, that's been a challenge. I think nationally they've been talking about repeated.
So we've had contact with Chris, so we're going to take this back and research it, and we will get back to you on it. So thank you for that question. Okay.
On that mental health, there used to be a walk-in, they changed it, we have to get a question from the doctor.
Yeah, that's right, exactly. If you have an appointment, I'm a psychiatrist, I see patients there. So when I book a patient into my schedule, I ask them to book into it, they get the round trip travel. If they're eligible for that, that's right.
On that travel pay, they changed from $6 to $8 to get back now, so that for a year.
Right. We will research that. We'll get that out. We'll also put that information onto via our communication channels for more veterans that might be interested in that answer there. Next question is the question is how do I get, I guess this person wants to get evaluated for screening for PTSD. So they're asking, what is the process that they have to go through to get a screening for PTSD determination? I don't know if that's a UDA question or if that's a EHA question.
From the VHA side, certainly for PTSD evaluation, we have walk-in appointments in both in all the primary care clinics. If you're in a mental health clinic, we can have a person walk in, we can see them, we can evaluate for any condition, depression, PTSD, any of those conditions can be seen. That part of it I can address. And we can do that same day services. Now, with regard, I don't know the VDA side, how that component is.
So if you feel like you have PTSD as a result of your military service, you file a claim, and basically we verify whether you were in a combat zone, or you can provide a statement saying that you had fear for your life. And then if we verify that you would have been in that kind of situation, we'll set up an examination to determine if in fact you have a diagnosis of PTSD and the level of the disability.
Okay, thanks, Kelly. All right, the question here is, how can I get a list of addresses of CHAMP VA doctors in the Las Vegas City area? Whoever asked that question.
So CHAMP VA is a national program that we don't run out of here out of Las Vegas, run out of Denver. And the person is asking for a list of doctors that may be available to CHAMP VA there. Whoever that is, we can get with you and provide the number you can call to find that out. Because only certain physicians do provide that back here. And you have to be eligible for this program. It's not what everybody would get.
Thanks, Jim. And that is, we can have your contact information, so we will make that, take that for action and follow up with you on that contact information. Okay, I think this question maybe gets back to our insurance capture information. You probably see the flyers around the hospital on that. So the question is why is the VA subsidizing their budget by collecting money that's been paid for? I think that might be more why we capture insurance information and bill third-party insurance for non-service connected things. So I think that's the budget question. Do we want to talk a little about it?
Well, it's a law that we do that. And it actually is part of our budget that we have that we collect from third-party insurance. So that's the answer. It is law, and we do ask our veterans for that information.
All right, the next question here is, how can I get a service dog?
VA does not provide service dogs, okay? There are organizations that provide service dogs, and you would have to connect with one of those organizations, maybe Blind Nose Guide Dogs for the Blind and those kind, but there are other organizations that provide guide dogs. And if it is a certified program for a service animal, the VA does help defray the cost of the veterinary care for that animal. But VA does not provide the actual dog, okay?
Great. All right, Dr. Contreras kind of gets back to our theme of alternative ways of taking care of pain medication. The question is, why can't the VA provide full body acupuncture and chiropractic services by schools? I believe we do chiropractic services here for pain. They work with me at South Dakota VA, so I think maybe a little education do chiropractic services.
Yeah, we have chiropractic services here. We have multiple chiropractors on staff here. So we have 3 chiropractors. In fact, we have teamed up with the university. We'll soon have chiropractic trainees on top of that. They'll be coming in, working with our chiropractors. Will be a training center on top of that. So that occurs. We get to the pain center here. Your primary care doctor certainly can make the pain referrals. We can have that evaluation, get that. And we do offer full body acupuncture, Dr. Noguera, and a couple of other physicians who provide full body acupuncture at this location. We do both full body and regular acupuncture, so both are there. So full range is available. I'm not quite sure why in this case, if you can get it referred from your primary, it can easily be done.
Thanks, Dr. Kate. And then here's one that's all of our favorite topics, whether you're an employee or a veteran here, and Mr. Stesso, if you want to talk about this one too. Due to Las Vegas being one of the fastest growing VAs, what is being done with the parking lot for now and in the future? And I think we've made some great changes recently that might help.
Yes, recently we changed a few things, we changed around our employee parking lot. So you shouldn't see any employees parking on patient parking for the last few weeks. And that's obviously where, because the employee lot has become more full. We also are going to reactivate 136 more employee spots in the back. That will alleviate some of that, around the backside of the facilities to that construction. We're just wrapping up that project, doing the final inspection, and hopefully by the end of January, mid-February, that will be open again to do that. So hopefully up in the front, we will see more parking available, and it's not as big of an issue. Obviously, it's not designed as good as we'd like it to be, and in the future we'll work on that. You know, we're very fortunate here to have as much parking as we do. Some of us have worked around the nation, other VAs, where you have to be shuttled in, and you don't have local parking that we have here. It creates another challenge. So we're always cognizant of that. We're working on that. We're always looking at our number of handicap spots as well. We do exceed the number of handicap spots by law that we're supposed to have. Obviously, with our population, that's still a challenge because we do have a lot of people and employees who need those spots. So we're always reviewing those and jumping into those and working with our union partners as well to make sure we have enough and in the right spots as well. So.
Thanks, sir. Kelly, this one's for you. We talked a little bit at our last town hall. I think this is kind of a similar question about this. There was a discussion at our last town hall about how ratings for disabilities is currently being reviewed and updated. Is there an update on that or a status on where they're at in that process?
There's no update on how far we've gotten through so far, but we are revising, what you're referring to is we're revising the entire rating schedule for all disabilities. And this is the first time this has been done since 1945. So much needed. The purpose is to bring how we determine disability ratings in line with non-resident, because we've made a lot of advancements over the past 10 years, let alone 60 years. So we're really looking forward to what that looks like for everybody in the future. And the intent is also to improve claims processing timelines so that it's easier for claims processors to make decisions and to provide more standardized decisions across the board for veterans and with disabilities.
Great, thanks, Kelly. Here's another one that's, this is a good question. I think Mr. Hearns kind of talked about this a little bit, but I think we're actually moving in this direction. So, will there be a time when a veteran can use technology to use a doctor, such as doctors on demand? And this gets into, you know, some veterans don't feel comfortable leaving their homes, and it might save time for veterans to not have to visit VAs or receive their care in their homes. We're actually moving in that direction. So, Dr. Kate, you want to talk about that a little bit?
Yeah, I can tell you, just if you look at the trends in the healthcare system, even in the last year, so I'll just look at the most recent data. Nationally, the number of hospital beds have declined, and they will continue to decline. You will see fewer and fewer beds across the nation. So, well, it doesn't look like Las Vegas. We're adding in all these little mini hospitals that are 24-hour beds or 48-hour beds or something. I said, well, we have a growing population, but across the country, in fact, hospitals are declining and shutting down. Eventually, the hospitals will, in my opinion, will go the way of the malls. Who goes to the mall anymore? I mean, it's rare, right? Isn't it? I was there last night. I was at the Meadows Mall last night. So you and I are the only two that go to the mall anymore. But most people don't. They just pick up and they go on Amazon and get their stuff through Amazon or whatever, right? That's what they do. So I think hospital increasingly in the trend, if you look at the national trend, hospital beds are declining. In fact, the industry nationally is actually, the inpatient type of industry is declining. So increasingly, the care is moving to outpatient settings. And the next step, really, care will be wherever you're at. And we're going to get, as we get right now, we're at the infancy of wearable devices, right? These smartwatches and things, smartphones and all this. We're getting in the near future, which within the next 5 years, you're going to see this more and more wearable devices that are monitoring at all times what your blood sugar is going to be doing, what your blood pressure is doing, whether you're having, potentially, are you having a bleed, are you having potential, colon cancer, it's going to be cancer monitoring. In fact, someone I know has actually worked on this device to look at early surveillance, and this is being done at Stanford, of cancer cells, so we can begin to watch these cells at the very beginning. I mean, all of these are gonna be wearable devices, which will then be connected to a hospital, clinic, or your doctor's office, or that. So care will get home. What we do right now, first we have home-based primary care. Some veterans in our own system are getting care in their home. We have healthcare nurse practitioners who go out and see the veterans at home, and you might know some people that are getting that. That's one option. We also provide home telehealth. There's some telemonitoring at home. It could be blood pressure or tracking blood sugar, so that we're doing that. But you're going to see that dramatically change, and you'll become a lot more care at home, so that most of us don't have to pick up and go somewhere to get care. We should really ultimately get to the point that you don't need two different settings. You're being monitored at all times in a sense. We're already being monitored by eye in the sky wherever we go, et cetera. But our health will be monitored at all times. That's what I think we're going to get to.
So to answer that question a little differently, this year we will be doing more into the care, into the home care. So don't be surprised if, let's say you missed an appointment, you weren't able to get there, and your doctor dials you up on the computer and talks to you via your computer. We have that technology now, and we hope to increase that this year slowly but surely, because you gotta have a camera on one end and a camera on the other end. But all of our providers are being provided with a camera on their end, so that we can hook up with you in your home, and you can maybe ask a question that way, or maybe you're feeling bad and you want to talk. So we're going to see more of that kind of care. And I think that was part of the question. Another thing that we hope is coming this year is that if we have your phone number, your mobile phone, we'll be able to text you about your appointment. All my doctors do that, so VA is moving towards that. We hope by the summer, is what they're telling us, that the texting will be available. So slowly but surely, we're moving into the 21st century, and I'm really excited about the opportunity to maybe be able to have these communications really quickly via your phone and an app.
All right, and then one question I kind of wanted to talk about here is, and we get this question quite a bit, is related to non-VA care, employment processes and that. We want to kind of talk about where we're going with that. I was still waiting for legislation on exactly what that community care is going to look like. The legislation has expanded the funding for the current choice program, but we're expecting to see some changes in that, depending on how that legislation gets passed. But I know that the VA is working to try to take some of those processes back in the house, so that we aren't putting the veterans out there scheduling a couple of things.
Yeah, that is one thing that new legislation will bring, is that the scheduling of the appointments will come back to the VA. We will schedule your appointments again. But until that law is passed and figured out, we continue with the process we have now, where we send your consult to our third-party administrator, which is Troy West, and we have a Troy West representative here today, right there. We will continue that process until they change the law, and we move that back in-house.
Great.
What is the difference between a choice program consult and a referral from the VA to maybe a practice that isn't available in-house or is too busy to have patients?
Well, most everything rolls to the choice program now, because that's where our money is. So it goes, the referral or the consult goes to TriWest, and then they have a group of doctors, a whole long list of people that they send people out to. If they cannot offer that to us, then we can send it out ourselves. So we can do a non-VA care referral out to the community, but most everything rolls through TriWest.
Dr. King, this is probably something that's been in the press lately. There's been a lot of press around the nation about credentialing healthcare professionals and that. And as a result, all the VAs have kind of gone through another reviews, looking at licenses, making sure that there are no practitioners with suspended licenses and that. But we just completed our review. I'd like to share with the community what our results were.
Right, sure. So this issue came about, actually arose just not too long ago in Iowa City. They had hired a surgeon who had actually lost a license in another state. And so there was an issue of how much did they track and how did they get hired. There were issues where the surgeon started to work, and so the tracking. So the VA said, well, let's go back and see how strong is our program of looking at the history of the doctors and really all healthcare staff, not just doctors, nurses, all independently licensed providers also, right? So take a look at where we stand. So we ended up going around and doing like a complete 100% review and doing really where we need to do, once again, primary source verification. Now, many doctors, as you know, have licenses in 3, 4, 5 states because they travel and whatever. And a lot of times you just let your license go 1 or 2 states. Some people say, I don't want to keep one because each state license can be $1,000. Somebody wants to pay $5,000 a year for licenses. So if they just let it go on their own, that's fine, that's reasonable, and they make decisions. If they actually lost the license, a couple of things should happen. One state board is supposed to communicate with all other state boards saying, wait, we took away this provider's license, you need to know that. So we went back and did a 100% review, and fortunately we found no one with issues. We were able to fix it. And in fact, the only things that we found were people made that incorrectly entered their own information one way or another. We went back and fixed it and said, look, this is the way it's done. But we got no one on our staff like that they had an issue in Iowa City where they had somebody lost a license in another state. So that were people arbitrarily removed in another state. So we had none of that. We did a 100% review and we submitted to VA central office yesterday.
Great, thanks, Dr. Dave. And I know that we have a phenomenal credentialing team here, and sometimes people complain about us taking the time it takes to get a doctor on board, but they're very thorough, so we just wanted to make sure that you were aware that our local VA is following national policy and law. Final question here is regarding, gets back to homelessness, and kind of the question is, what are some of the support services surrounding VA-funded housing for homeless veterans for the future? Kind of what are we doing for our homeless here in the future, and do we have any plans within the VA to help prevent homelessness? Somebody want to take that one?
Well, we have many programs under the umbrella of homelessness. We have a grant per diem program where we can house people very quickly that are homeless. We have the HUD MASH program, which is a cooperation between the VA and Housing and Urban Development, where we have vouchers that we can give veterans to get housing in the community. We have, I'm going to say, at least 50 people that work for us in the homeless program. They go out and find our homeless veterans and bring them in for treatment and help with finding housing. We partner with the community because there's many, Salvation Army, USF, Vets USA, that provide crisis housing for homeless veterans. So we have quite a program here in Las Vegas. In fact, we were one of 25 cities that was part of the Secretary's initiative a couple of years ago that did get functional zero for homeless veterans. And what that means is that we have the vouchers available if the veteran wants them. So that's what functional, and we have to constantly work to keep it functional zero because people are moving into Las Vegas all the time. And with people moving in come people who don't have homes and they're veterans. So our social workers are out every day looking for those homeless veterans and how we can help them. There are some people who don't want to be home. They don't want a house. They don't want a place to live. They want to be on the streets. So we try to encourage them to get the treatment to help them with whatever their issue might be. So yeah, we have a big.
Yeah, and I think we're a national model too because of what we've done as far as our partnership with the county and the community and the private organizations. So we've been upheld as a model. So and we just recently dropped, the Las Vegas community recently dropped out of 2017 point in time. We'll get ready to do 2018, but for 2017 we dropped from the 3rd highest homeless veterans population in the nation down to the 4th. So we are making that progress. So and try to take care of our veterans. So
Yeah, it's not just us. We work with the community, so they also help us house veterans and help them with treatment. So that's part of this whole fair that's happening today is helping veterans.
Question, is there a place to go online to follow the eligibility criteria for accessing the voucher for this program?
Yeah, there's a whole site, and I'll give you the website afterwards. There's a whole VA homeless site that has a whole list of resources for providers as well as community, and I'll be happy to help you with that. Yes.
I just want to know if SSDF and the private funding for homeless veterans, that,
Yeah, we're part of the SSDF program, which helps families.
that-
of homeless veterans.
is that part of the, who funds SSDF, is that private?
No, it's, I think, I'm not an expert on the funding of it, but I believe it's government, that part's government.
Yeah, there's some grants.
They're grants that we give to organizations that help,
Okay.
do that.
Do they have limitations on them?
That I can't answer for you, but I might have somebody out in the hallway here, one of the booths that can answer you.
I believe we do have our social work program out there, and they're the experts on that, because like we said, in most cases with everything within the VA, each veteran's situation and their circumstances, criteria, quality are a little bit different, so I would say recommend to do one-on-one. Well, we have taken our hour of time here, so we do need to wrap up our town hall. There's another activities going to be taking place in this room here in just a few minutes. So we have some other sessions here today that will be available to you. There will be breakout sessions on veterans benefits where we have Bernie Lipscomb, who's one of our experts on outreach for veterans benefits. We'll be here talking about that specifically. We also, for our post 9/11 veterans, we will have a session at 12:30 as well, one of our classrooms here on transition management. So about being here services for our younger veterans that are post 9/11 come out of service. We also have a session that will start here at 1:15 about VA home loans. And we also have a session about financial fitness. And then we have two sessions in out today about, there's going to be one here in the auditorium and two about alternative therapies that are available. And then there's another session that will be taking place in partnership with the Elizabeth Dole Foundation and Hidden Heroes to talk about support for caretakers. So lots going on still here today. We want to thank you for taking the time to come spend a little time for us to learn a little more about your VA. Please take those newsletters with you. And on the back, there is a list of different places where you can sign up and get news and information in real time about VA, what's going on here at your VA locally, and we encourage you to do that. So thank you for coming out and have a great day.
Thank you for being here.